Welcome to The Explainer. Tonight, we're unpacking a really fascinating and honestly incredibly high-stakes medical puzzle, one you're definitely going to face in the ED or the OR at some point in your career. We are talking about the management of toxic multinodular goiter. By the end of this, we're going to take this clinical mystery and turn it into complete mastery, making sure you have the exact strategies you need to safely navigate this whole thing.
All right, picture this. It is 2 a.m. on your surgical call. You're asked to manage a 72-year-old woman who just rolled in. She's a nuanced at AFib with a rapid ventricular response. You take a look at her labs, and her TSH is totally suppressed. We're talking less than 0.01, while her free T4 is mildly elevated. You walk in the room, do a quick neck exam, and right away you feel this massive, knobby, non-tender goiter just descending right down behind her clavicles.
So you're at the bedside evaluating her, and your eager intern turns to you and says, hey, let's get a high-dose radioactive iodine scan and then load her up with Lugol's iodine solution to calm the thyroid down before we consult surgery. I mean, it's a super common thought process for hyperthyroidism, right? So do you approve that order?
Stop right there. Because if you say yes to that intern, you might just trigger a massive, life-threatening thyrotoxic crisis. We're talking a full-blown thyroid storm. This happens through something called the Jode-Bisdow phenomenon, basically severe iodine-induced hyperthyroidism. See, unlike other forms of hyperthyroidism, this patient's goiter is packed with autonomous nodules, acting like rogue factories. If you feed them the exact raw material they're craving, which is iodine, you are literally pouring gasoline on a fire. No way. Okay, let's dive into this. To make sure we never make that 2 a.m. mistake, here is our roadmap for this explainer. We'll start with the pathophysiology, cover the strict diagnostic rules, walk through medical stabilization, look at definitive treatments, and wrap up in the OR with some crucial surgical wisdom.
All right, jumping right into part one, the pathophysiology of autonomy. Why does this actually happen? The cellular level brilliantly illustrates the difference between the two main heavyweights of hyperthyroidism. Think of a normal thyroid gland as a high-tech smart home heating system controlled by a central thermostat. That's your pituitary gland releasing TSH. Now, in Graves' disease, a faulty wire, like stimulating autoantibodies, forces that central heater to run constantly. But in toxic multinodular goiter, or TMNG, the central thermostat is actually working perfectly fine. The problem here is that someone plugged a bunch of independent space heaters, our autonomous nodules, into the rooms. They completely bypass the central thermostat, run at absolute max capacity, totally ignore the room temperature, and just overheat the entire house.
So how exactly do these rogue space heaters pop up? Well, it's a multi-decade saga. Step 1. It usually starts in areas of low iodine intake, which causes the thyroid to undergo diffuse hyperplasia, just to try and compensate. Step 2. As these cells replicate over and over for years, certain clones pick up genetic mutations, most commonly in the TSH receptor or GNS1 genes. Step 3. These mutations act like a permanent switch, locking the cellular engine on, even when there's zero TSH around. And finally, step 4. The toxic state. The cumulative hormone production from all these nodules absolutely skyrockets, shutting down the pituitary TSH entirely. And the crazy thing, the normal, healthy thyroid tissue actually just goes to sleep because the TSH is gone, while these autonomous clones run totally wild.
Moving on to part 2, let's look at the diagnostic rules and some major pitfalls you need to avoid. So according to the American Thyroid Association, the gold standard diagnostic algorithm needs both biochemical confirmation and imaging. On the labs, you'll see a suppressed serum TSH, usually well under 0.1, paired with an elevated or sometimes normal free T4 and free T3. Just a quick side note, in elderly patients, an isolated elevated T3, which we call T3 toxicosis, is actually really common. But the absolute gold standard for nailing down TMNG is a radionuclear scintigraphy, or a thyroid scan. You're looking for this classic pathognomonic patchy appearance. It'll show multiple areas of increased tracer uptake, those are your hot nodules, set right against a background of suppressed, sleeping, normal tissue, which are the cold areas. Now, if you take away absolutely nothing else from this explainer, you have to remember this golden rule. Never, ever biopsy a biochemically and scintigraphically proven hot nodule. Seriously, just don't do it. Why is that rule so absolutely crucial? Because hot nodules are almost never malignant, but their cellular cytology often shows hyperplastic features that look exactly like follicular neoplasia.
If you go in and biopsy a hot nodule, you are basically setting a trap for yourself. It's going to look like cancer under the microscope, which leads straight to a misdiagnosis and unnecessary, potentially total thyroid surgery. You've got to remember, TNNG does carry a 3 to 5% risk of coexisting malignancy. But that malignancy, it hides in the cold, quiet corners, not the hot, active ones. So map the nodules with an ultrasound and target your fine needle aspiration exclusively on the suspicious cold spots.
Okay, so how do we fix it? Let's get into part 3, crucial medical stabilization.
All right, here is your immediate action protocol. First things first, you want to initiate a beta blocker, like propranolol or atenolol, immediately. This gets those hyperadrenergic symptoms under control, like that rapid AFib we saw at 2 a.m., and it also blocks the peripheral conversion of T4 to T3. Second, get them started on an antithyroid drug. Methimazole is your first-line choice here over PTU, mainly because it's got a longer half-life and a much lower risk of hepatotoxicity. You'll dose that at about 10 to 30 milligrams daily. Your ultimate goal in the stabilization phase? Achieve clinical and biochemical euthyroidism. You basically just want to get their levels back to normal before you even think about any definitive intervention.
Now pay very close attention to what is completely absent from this protocol because it's the ultimate prep secret for TMNG. Unlike Graves' disease, routine use of Lugol's iodine or SSK is strictly prohibited, and this ties right back to our eager intern from earlier. If you give iodine to a TMNG patient, it triggers that massive jaw-based effect we talked about, sending those autonomous factories into absolute overdrive. Again, just don't do it. Once they are stabilized, we move to part 4, definitive treatment pathways. The thing about toxic multinodular goiter is that it never, ever undergoes spontaneous remission. We have to intervene definitively. Now, if we look at the American Thyroid Association, the UK's NICE guidelines, and SAJA's surgical guidelines, there's actually a pretty solid consensus based on how the patient presents. For non-compressive disease, radioactive iodine, or RAI, is widely preferred, especially if you're dealing with the elderly. But the second you have a compressive goiter, meaning it's physically pushing on the airway, every single major guideline points straight to the operating room for a total thyroidectomy. So that sets up a really clear contrast between our two pathways. Pathway A is radioactive iodine. Remember the pathophysiology we just covered? The normal tissue is asleep. Because of that, the RAI brilliantly targets only the hot, autonomous nodules. It completely spares the sleeping tissue, which often prevents permanent hyperthyroidism. It is a fantastic option for high-risk, older patients. Then you have pathway B, total thyroidectomy. This is your absolute go-to for large, compressive goiters, anything extending down into the chest, or if you happen to find a malignancy in one of those cold nodules we talked about mapping out. Let's step into the OR for our final section, some essential surgical wisdom. Doing a total thyroidectomy for a massive goiter is incredibly anatomically demanding. You've got to protect your key boundaries. First up, the recurrent laryngeal nerve needs to be fully dissected and visualized along its entire course. Absolutely no blind clamping. Second, you have to identify all 4 parathyroid glands and meticulously dissect them off the thyroid capsule to save their blood supply. And here is a fantastic senior attending level pearl. If a parathyroid gland accidentally loses its blood supply during dissection, you don't just throw it away. You mince it up into tiny 1 millimeter fragments and auto-transplant it straight into the sternocleidomastoid muscle. It'll actually revascularize and keep functioning right there. But maybe the highest stakes warning in the OR is the tracheomalacia trap. Listen, if your patient has had a massive compressive goiter leaning on their airway for, say, 15 or 20 years, all that chronic pressure can literally soften and destroy the cartilaginous rings of the trachea. When you finally remove that heavy goiter, the trachea suddenly loses its support and can just collapse on inspiration. So always have a tracheostomy kit ready in the room, and you absolutely must perform a leak test before you extubate. Finally, the surgery is a success, and you move the patient to recovery. You're going to draw their intact parathyroid hormone level 1 to 4 hours post-op, and you are looking very closely for one specific number, less than 10 to 15 picograms per milliliter. If their PTH drops below that threshold, it is a massive red flag predicting impending hypocalcemia. By catching that number early, you can proactively start oral calcium and calcitriol before the patient ever even starts experiencing tingling around their mouth or muscle spasms. So we've gone all the way from the cellular origins of autonomous mutations right through to post-op recovery. You've seen exactly why the normal thyroid tissue sleeps while the rogue nodules run wild, and more importantly, how to manage them safely. I'll leave you with this.
The next time it's 2 a.m. and you face a massive neck mass with atrial fibrillation in the ER, will you recognize the rogue factories before pouring gasoline on the fire? Keep these clinical pearls close, and you'll master the management of toxic multinodular goiter every single time. Thanks for joining me on this explainer.